This video covers bag valve mask, or BVM, ventilation, which is a critical skill in both basic and advanced life support. BVM ventilation is a manual procedure providing positive pressure to patients who are not breathing adequately. It's often called AMBU bagging and is the single most important skill in pediatric resuscitation. Indications for BVM include respiratory arrest, respiratory failure, and pre-oxygenation before intubation. It is also used when transporting unstable patients. Absolute contraindications are rare, such as complete upper airway obstruction. Relative contraindications requiring caution include congenital diaphragmatic hernia and tracheoesophageal fistula, where intubation is often preferred. The main parts of the AMBU bag are the self-inflating bag, which does not need a gas source to re-expand, the air inlet one-way valve, and the patient outlet. The pressure release or pop-off valve prevents lung injury or barotrauma. It is usually preset at 35 to 40 centimeters of water, allowing excess air to escape, though it can often be overridden for higher pressures. When performing BVM ventilation, the oxygen concentration, or FiO2, delivered depends on whether a reservoir is attached. Pediatric face masks must cover the nose and mouth without covering the eyes or hanging over the chin. Neonates often use round masks, while older children use anatomical or triangular masks. The sniffing position aligns the oral, pharyngeal, and tracheal axes. For infants with large occiputs, place a shoulder roll to slightly extend the head and achieve the correct position. In the one-person ESIC clamp technique, the thumb and index finger form a C to seal the mask, and the remaining fingers form an E to lift the bony jaw into the mask, avoiding soft tissue pressure. The two-person technique is used for a difficult seal or hand fatigue. The first rescuer uses both hands for the ESIC clamp and jaw thrust, while the second rescuer squeezes the bag. This provides the best seal and tidal volume. The correct ventilation rate depends on the patient's age and clinical scenario. Tidal volume should be just enough to see visible chest rise, approximately 6 to 8 milliliters per kilogram. Avoid excessive volume to prevent pneumothorax and gastric distension. The primary sign of effective ventilation is an increase in heart rate to above 100 beats per minute. Secondary signs include visible chest rise, improved color, and improved muscle tone. If the chest is not rising, use the MRSOPA algorithm. M is for mask adjustment, and R is for repositioning the airway. S is for suction, and O is for opening the mouth, possibly with an oral airway. The final steps of MRSOPA are P for pressure increase, up to 40 centimeters of water, and A for alternative airway, such as intubation. Gastric distension is caused by air entering the stomach, usually due to poor positioning or excessive pressure. Manage this by inserting an orogastric tube if bagging for more than 2 minutes. Barotrauma, such as pneumothorax, results from excessive peak inspiratory pressure or volume, often due to a closed or malfunctioning pop-off valve. The oropharyngeal airway, or OPA, is indicated for unconscious children with airway obstruction by the tongue. Size it from the center of the lips to the angle of the jaw. Do not use it if the gag reflex is present. For reusable bags, disassemble and wash the parts, then sterilize. Methods include autoclaving for silicone, chemical for heat-sensitive parts, and gas for plastic parts. Test the bag before storage. Key reminders: pop-off valve pressure is 35 to 40 centimeters of water. The best indicator of effectiveness is an increase in heart rate. Oxygen concentration is 90 to 100% with a reservoir bag. Additional rapid-fire points include a ventilation rate of 40 to 60 breaths per minute for neonates, and the correct OPA size is measured from the corner of the mouth to the angle of the mandible. A previous year question confirms the pop-off valve pressure is set at 35 to 40 centimeters of water to prevent barotrauma. If the chest is not rising, the first corrective action is to reapply the mask for a better seal, following the M step of the MRSOPA algorithm. The recommended ventilation rate for a newborn is 40 to 60 breaths per minute to ensure adequate gas exchange. To deliver 100% oxygen using a self-inflating bag, a reservoir bag is mandatory as it prevents the bag from entraining room air. Congenital diaphragmatic hernia is a relative contraindication because BVM can push air into the stomach, expanding it and further compressing the lungs. The correct hand position for a single rescuer performing BVM ventilation is the CE clamp. When selecting a mask for a neonate, it must cover the nose and mouth but not the eyes. The correct size of an oropharyngeal airway is measured from the corner of the mouth to the angle of the mandible. The tidal volume delivered by a pediatric self-inflating bag is typically between 250 and 500 milliliters. Gastric distension during BVM ventilation can be minimized by giving slow, gentle breaths with just enough volume for chest rise. Remember these golden points. Pop-off valve is 40 centimeters of water. Neonatal bag volume is 240 to 500 milliliters, and the rate is 40 to 60 per minute. To perform a safety check, block the outlet and squeeze the bag. Resistance should be felt, and air should escape from the pop-off valve. When released, the bag should quickly re-expand. Adult and pediatric BVM devices differ primarily in size and volume capacity. In summary, prepare the equipment, position the patient, use the ESIC clamp at the correct rate, and watch for visible chest rise. If necessary, troubleshoot using MRSOPA. In a scenario with an apneic newborn and heart rate of 80 beats per minute, start positive pressure ventilation immediately. If the chest is not rising, follow MRSOPA steps until the chest rises and the heart rate increases. Thank you for watching this video. Best of luck with your exams.